this is a special time because Federico and Mark and I have not really seen each other for a couple of years, it seems like. So this is, and we've now seen each other for about 35 seconds. So greetings to the two of you guys. Certainly for all the attendees, we really appreciate you joining us during this a global pandemic and times of tremendous social unrest, especially here in the United States. So we appreciate your joining us and hope that this seminar gives you a break from reality. I also want to take a few seconds just to thank Edra. Edra is a large publishing company in Europe. I think their home office is in Milan, in Italy, and I want to thank them for the quality of the work, their professionalism in producing really a beautiful book that is absolutely top-notch. And of course, we want to thank Tommaso Альбонетти, who actually organized this webinar along with Enrico Febo, who's in Italy. And a brief story about the book. The book was put together when we began to think that enough information had been gathered by clinical researchers and basic science researchers to better understand endocrine problems in cats. We had finally reached a point around 2016, 2017, just a few years ago, where the three of us felt that there was enough information coupled with tremendous interest among veterinarians, veterinary students, cat owners in hormone problems in cats. So I think what we tried to create was a concise and complete information resource on pathophysiology, clinical signs, differential diagnosis, treatment, prognosis of endocrine problems in cats. We put together a table of contents, some chapter titles that we thought would represent all the topics under this umbrella that we would be able to present to readers around the world. We actually identified 45 people to join the three of us. Actually, every one of those people agreed to join and write or contribute to chapters in this book. So I think the resulting product is just really fabulous. I love looking at the book, and people ask me questions, and I'm looking things up in that book all the time. So I think with that kind of introduction, Mark or Federico, I should introduce the two of you. Federico Frakassi is a small animal internist at the veterinary school in Bologna. He has a fabulous interest in dog and cat endocrinology, and is extremely experienced. He has fabulous experience in diabetes mellitus, which all of us appreciate in dogs and cats has to be one of, if not the most common endocrine disorder in both species together. So Federico, we're really super lucky to have you here and to have you participate in that book. And then our third colleague is Dr. Mark Pedersen, who is world famous for his clinical research in small animal endocrinology. He's the owner and director of the Animal Endocrine Clinic, which is a specialty referral hospital in the New York City area, devoted primarily to the diagnosis and treatment of cats with thyroid diseases. He's also an adjunct professor of the College of Veterinary Medicine at Cornell University. So we're really lucky because when we talk about endocrine disorders in cats, there's a wide variety. Virtually every hormone problem that occurs in dogs or in humans probably occurs to some degree in cats. In many areas, cats seem to be small people more than small dogs, and this is why we needed to develop expertise specific for cats. But knowing that diabetes mellitus is extremely common, and knowing that hyperthyroidism is extremely common, these are disorders that all veterinarians in small animal practice see routinely. So we have the world's expert in diabetes mellitus in cats with us, and the world's expert in treating and diagnosing hyperthyroidism. I would venture to say that Mark Pedersen has not only diagnosed and treated more hyperthyroid cats than anyone else, he's probably the most peer-reviewed person. So that everything he does, he publishes, which means it has been presented to veterinarians around the world. And virtually every single time, what veterinarians around the world do is adopt Dr. Pedersen's approach to diagnosis, treatment, prognosis, whatever, knowing that the work is really solid. Federico's a little bit younger, so he doesn't have quite as many peer-reviewed experiences as does Mark. But I think if it's okay with the two of you guys, I'll ask Federico a question on diabetes, a question or two, and then I'll go over to Mark and ask a question or two on hyperthyroidism. Is that okay?
Perfect.
Fine.
Great.
Thank you, Ed.
So the first question I would ask Federico is the simplest one and the one we all think about. You see a newly diagnosed diabetic cat. What do you tell that owner are the chances are of this cat going into remission? And does your opinion change if the cat was ill with diabetic ketoacidosis when the cat was first presented at your hospital or at a referring veterinarian's hospital? Or if the cat was simply seen because of polydipsia, polyuria, and weight loss?
Good question. Thank you, Ed. And hi, everybody. It was a big honor for me to be here and be part of this group. And let's start talking about diabetes and diabetes remission. It's a really important topic because when we mention diabetes remission to an owner, of course is very happy to join this to achieve this possibility. Usually I don't talk immediately about diabetic remission with an owner because if they understand that the main aim is remission, if this cat is not going to remission, maybe the owner can be frustrated. How many cats are going into remission? We don't know exactly, because when we look at the literature, there is a recent paper published in United Kingdom in first opinion practices, and the probability of remission within the first year of treatment was 13%, so pretty low. And when we look some papers publishing with some I would say some aggressive approaches in referral center or not referral center is until 60%. So which is the percentage of cats that are going into remission? Probably in my personal experience is around 25% of cats, if treated properly with insulin and low carbohydrate diet with appropriate monitoring, they are going into remission in about 25% of cases. And of course, when we look at the cat for the first time, we think, are you going into remission? Are you able to go into remission? And you mentioned already some condition. For example, we know for sure that cats that are diabetic because they receive some medication, corticosteroids, they are absolutely prone to develop going into remission. And several authors try to find some markers of remission in cats. And in some papers we can find, there is a paper that says that cats that are arriving at the clinic with ketoacidosis are more prone to develop remission. There is another paper that observed that older cats are more predisposed to go into remission. Cats without hypercholesterolemia are prone to develop remission. One recent study published at the RVC, the Royal Veterinary College, observed that the only factor associated with remission was the loss of weight in the first month of treatment, especially in overweight cats. Cats that were able to lose at least 2% of body weight, they were able to go into remission with more probability. But if I have to tell which is a clear method, a clear way of saying this cat will go into remission, we don't know. Probably a study looking at the C-peptide would be very useful, because in people the concentration of C-peptide is related to the remission, but the problem is that we have problems in measure C-peptide in cats. Was done in dogs, but in cats is problematic. So we don't know, but for sure in a very fat cat that is able to lose weight, a cat that was receiving corticosteroids and then developed diabetes, and probably cats that are arriving in the clinic with ketoacidosis, they are more prone to develop diabetic remission. And then we could talk for hours about diabetic remission, because we don't have a clear definition of remission. In humans, it is 1 year of normal glycemia, and there is a partial remission when the blood glucose is between 100 and 125 milligram per deciliter, and a complete remission when it's below 100 milligram per deciliter, the fasting glucose concentration, for 1 year. In cats, we don't know. We decided, there was a sort of meeting that decided that probably 1 month could be considered enough of normal glycemia without treatment, could be considered appropriate to define remission in cats.
Well, wow, thank you for that. That's wonderful. As you were talking, I thought maybe I should just define C-peptide. So when insulin is synthesized in the pancreas, it's a long chain of amino acids. And before it becomes active, a group of amino acids, a connecting peptide, is cleaved off, leaving 2 chains that are connected. That connecting peptide is called C-peptide. There is no C-peptide in commercial insulin. So when you give a patient with diabetes injections of insulin, they have no C-peptide. So if you take a patient, dog, cat, person, doesn't matter, you take any individual and measure C-peptide, you are measuring actually how much insulin that patient is producing endogenously, which can be of value. We would assume, and a number of studies have shown this, and when you measure C-peptide in dogs that have diabetes mellitus, you measure none, because dogs have an absolute deficiency of insulin. That's the best example I can give. So I do understand avoiding talking about remission so that you don't get owners having disappointment. That's beautiful. But I think everyone who listens to you treating, and you said treating cats, you know, with the correct dose and all that kind of stuff, I think most of our listeners would be very curious to know what insulin you begin with, what dose, how frequently, how, and maybe an impression as to how competent your owners are.
Yeah. About the insulin, I personally like to use glargine, because of course we have many studies that evaluated this insulin. There's only one study that showed that seems to be better compared to other insulin, because the cats that were receiving glargine went into remission more compared to cats that were receiving other kind of insulin. But and probably the glargine, because of the absorption, because the cat has not this postprandial hyperglycemia that we see in dogs, because of the characteristic of the cat that is it wants to feed several times per day. An insulin like glargine seems to be good, but I don't think that probably the insulin is the main, the most important part in the management of diabetes. You mentioned about owner compliance and owner that are doing things in a proper way, proper monitoring. And so in the literature, we don't have so much evidence that the kind of insulin is so important. Looking at the physiology, of course, we like a long-acting insulin, also PZI is a pretty good insulin in cats. I personally prefer give insulin 2 times per day. And so glargine, and recently now I'm treating my cats with a new product that in the book is just mentioned because we are starting it, is the glargine 300 units per milliliter, is the Toujeo, is the brand name. Theoretically is the same insulin because it's glargine, only more concentrated, 3 times more concentrated. But Cheng Giller did a nice study on the pharmacokinetic. It seems that the duration of effect is longer, and we are doing at the moment a small trial on this insulin Toujeo. We are not comparing the insulin with other insulin, but it works really, really well, and with really flat blood glucose curves, and it's always a glargine insulin. But I would say in the guidelines of diabetes, there are several consensus guidelines. The 3 insulin that are most recommended for cats are glargine, and we can use the 100 unit per milliliter or 300 unit per milliliter, and the PZI or the Detamir. These are the 3 insulin recommended for cats because of the duration of the effect. And if we use the glargine or also the PZI, I usually like to start with a low dose. I usually start 1 unit per cat 2 times per day. And or in cats that are with a body weight more than 5-6 kilo, probably 1.5 unit twice daily. Usually I don't start with 2 units per cat. I like really to start with a very low dose, and already after 1 week or 5 days I already increase the dose. In veterinary diabetology, I think it's very good to always start with low dosages of insulin, always. And the same is for dogs. So we'll start with low dosages, and we increase the dose. If we use the Toujeo, the more concentrating insulin, probably we should start with a bit higher dosage because it seems to be a bit less potent. So in a cat, I start, for example, a 5 kilo cat with diabetes. If we use Toujeo, I like to start 2 units per cat 2 times per day.
That is outstanding. Well, we're going to give Federico
I have a
chance to
question.
catch it. Oh,
yeah, Mark.
What's the cost of the new insulin?
Oh, I cannot answer this question because I know that the Europe and US are 2 different words. When I was last time in US, so? I discovered how expensive. Can we talk about this? Because I discovered, I don't know if you are allowed, but do you know how much? Do you know how much does it cost? 1 pen of Lantus here in Europe, in Italy, where I work. It costs about $10 to $15 1 pen with, and I know that in US it's much more, right?
Yes.
So the Toujeo is a bit more expensive, but for us the cost of these human insulins are pretty low, so it's not a problem for us. But I know that in US this is really problematic. I have no clue about the cost of Toujeo in US.
Yeah, I don't. But there's no doubt that that a lot of the drugs available in the United States are phenomenally more expensive than they are in other countries. So it's a little bit embarrassing. Thank you. Any other questions, Mark?
Nope.
Now I get to ask you a question. Okay. So Mark and I are actually both old enough that I think it's fair to say that when we were going through veterinary school, hyperthyroidism was not presented to us in any lectures. It really is a condition that was first identified around 1979, 1980. So we're 40 years now into hyperthyroidism, which has become or seems to be an extremely common disease in elderly cats. So in all this time, Mark, do we know the cause? Is the disease increasing in its frequency? Is it simply more recognized, so veterinarians are testing more? We don't want to go into the frequency of disease diagnosis because of testing. That's a political thing.
That's right.
Yeah.
Well, I think it's both. I think we certainly, you know, when we first diagnosed this disease in the late 70s, early 80s, veterinarians weren't really looking for it. We went out, you and I, we went out and lectured about it, and people started testing. And now it's automatic for most veterinarians to just test for it. So we're seeing a lot that way and picking it up much earlier. But it also certainly over the years, if you look at studies, it's gone up and up and up, and it maybe it's plateaued out, but I think it's still very common, probably increasingly common. So we see it all the time. And it's been estimated that about 10% or so of cats older than the age of 10 have the disease. And I've always said, if cats live long enough, they'll probably almost all get the disease because it's a very common disease. As far as the cause, we don't know what the cause is. There's a lot of predisposing factors such as flame retardants. We published a paper recently showing that flame retardants certainly probably played some role in the pathogenesis. I believe that cats are just predisposed to getting it, and there's probably, in people this has been shown, there's cells in the thyroid gland of some individuals that are more predisposed to someday developing an adenomatous change or a thyroid nodule. And we think the same is probably true in cats. So there's this subset of cats, which probably are most cats, that have these cells that, given the right stimuli, will become a little adenoma and grow and enlarge and become an adenomatous lesion that we see in these hyperthyroid cats. So the bottom line is, we don't know the cause for sure. I think it's probably the cat itself is predisposed, and then there's these external factors, be it in the environment, flame retardants, plasticizers, something in the diet, or iodine, or water, or something, or air, that are predisposing this certain cat to make these cells within their own thyroid become little adenomas.
I have another question, but just out of curiosity, do you think the disease was, I'll use the word common because I don't know what other word to use. Do you think the disease was present in 1960, 1970, or is it a disease that appeared later?
I went back, when we first diagnosed the disease in the late 70s, I went back to our pathology records at the Animal Medical Center, and you were there, you know the pathologist there. And I went back starting at the beginning, when the AMC opened in the early 60s, and I looked at all the pathology reports, and there was no thyroid tumors in any of those cats until the early 70s. And then they were very rare. And starting about 71, 72, they went up and up and up and up until we first diagnosed our cats in 77, and then they went crazy. So the pathological changes, they were there early, but it was very, very rare, and they weren't common at all until the mid-70s. And this is like the flame retardants, for instance, and the furniture, the computers, and everything else, they weren't really around until that time. So it suggests that two things happened. First of all, these environmental factors probably came of age and they started being there. That's number one. And then number two, remember, the cats don't get this disease until they're old. So I remember being an intern with, you know, like when we were interns, residents said, if you saw a 12 or 13-year-old cat, that was a pretty old cat.
Yep.
Today, a 12 and 13-year-old cat's a middle-aged cat. You know, we never saw 20-year-old cats very often at all. Now it's and run of the mill that we see these old cats. So I think both of those, I think overall veterinary care improved enough, and that's one reason we're seeing more too, because it allows this disease to progress, these adenomas to get bigger and bigger to the point where the cats show clinical hyperthyroidism.
Yeah, I'm guessing that there's probably a corollary to the percentage of people who had indoor cats. because I'm guessing that the number of owners around the world who had indoor pet cats, say in 1960, that percentage also mushroomed into a huge number that we see today. So that's probably part of the picture. So
people didn't feed them or care for them.
Right.
They would keep them left scraps, table scraps. It wasn't balanced, you know. So overall, the cat care around the world has just gotten so much better over the last 40 years.
So I think it's fair, since we've talked about the disease, to ask you what test is best. I mean, are people still worrying about total T4 versus free T4?
Yeah, the problem that I see, if we're going to do one test, we want to do a total T4. And what I find is many of the labs say, well, the T4 is in the upper half of the normal range, so you should do a free T4. And then the free T4 will be just a little abnormal. And all of a sudden, in a cat without clinical signs or a thyroid nodule or anything else, these vets are referring it to me for radiation therapy or putting out methimazole or something else. So I just want to say that, first of all, cats have their own normal range for all these hormones. So just because the T4, if your normal range goes from 1 to 4 for total T4 or 10 to 50 or whatever, and it's in that upper half of the normal range, that doesn't mean that cat's hyperthyroid or is ever going to be hyperthyroid, because that could be completely normal for that cat. And the problem with the free T4 is it's a more sensitive test for diagnosing hyperthyroidism, but it can also be falsely high in many sick cats. So you have to look at the whole cat. You don't diagnose this disease on a thyroid level. You diagnose it looking at the thyroid level, but after first reviewing, talking to the owner and getting a history and examining the cat and looking for a heart murmur, a thyroid nodule, evidence of weight loss and other things. So we're going to do one test, stick with your total T4 rather than your free T4. There's no rush in diagnosing this early. And most cats are very easy to diagnose when they truly have the disease and they're clinical for it.
Mark, may I ask you something also? May I? Yeah, because I'm not a big fan of free T4, and I know all your study, and I like the total T4, and especially because now many laboratories are measuring free T4 with chemiluminescence, and probably it's not the ideal method to measure free T4. But I like very much after you publish some papers on TSH in cats. You are using the canine TSH in cats, and my opinion after looking at your papers and now, I much prefer to associate TSH to total T4 rather than free T4. If I have to invest money in assess the thyroid function, I like very much the total T4 and the canine TSH. I know that has some limitation, but what do you think about this combination?
Right. Well, TSH, remember, in a cat, is in people and dogs, there's this thyroid axis, right? So when T4 starts to go up, even very, very slightly, that T4 is going to feed back to the pituitary and shut off pituitary TSH secretion. So in hyperthyroid cats, even very mild hyperthyroid cats, you'd expect TSH to be undetectable, to be very low. So that's what we see in almost all hyperthyroid cats. It's undetectable. So like you say, if you have a T4 that's high normal and a TSH that's normal, that's not shut off, that doesn't really go along with hyperthyroidism. So that would tell us, well, maybe we shouldn't be in a rush to treat, maybe we should retest, and maybe that T4 being high normal is completely normal for that individual cat. Now, the problem with the TSH, the assay we have now, is about 25% of normal, clinically normal cats also have undetectable TSHs. So that TSH assay cannot differentiate between low normal and really low because it's not a very good assay. So there's hope. There's some assays that people are working on now that hopefully will be able to lower the sensitivity of the assay and do this in cats. So So I'm working on it with a company now, and hopefully that within the next year or two, that will be out, and that'll be helpful. That'll be great if we can do that. And I agree with you with chemoluminescence. When you do, if you don't do T4 by dialysis and you do T4 by free T4 now, free T4 by chemoluminescence, that's not really free T4. That's just, to me, another way to do a total T4. And I agree with you, doesn't really add that much.
Is the canine TSH that you have available to you, Mark, the same assay that Federico has? Is that assay
Yes.
Most veterinarians around the world or laboratories are using the same assay?
Yeah. It's all an Immulite assay, so it's used. It's the same assay.
This is great. Well, thank you. I do want to say, since I have some questions lined up to go back to Federico, but I would point out something about the three of us. And I think that I speak for the three of us when I say that we are semi-fanatical about the importance of history and physical examination.
Yeah, we're all clinicians.
Yes, we are all clinicians. And so when Mark said, don't diagnose hyperthyroidism based on a laboratory test, I think he is echoing the same thoughts that Federico have at the same time, and that I would have at the same time. And that is, never make a diagnosis just on a laboratory test. You must have that patient, the owner's observations, the owner's concerns, your observations put into a package with test results. Do you guys agree with that? Is that fair?
Yep.
Okay.
100%.
And I guess I'll point out an example. The example, and the three of us have this experience, and that is that someone will contact me and say, you know, I've got this 10-year-old dog, and here is the low dose dexamethasone suppression test result. What do you think? Without providing any information on the patient. And so that's why I like to always remind veterinary students, veterinarians, owners, that it is a package. One of these cannot be separated from the others. So I've heard a term recently called glycemic variability. And this has been introduced into veterinary medicine. But this glycemic variability is something that is referred to in human medicine. Can you tell us what that means, and do we worry about that in diabetic cats, Federico?
Yes, it's a very interesting topic, because in human diabetology, this concept has been introduced a few years ago and gained particular attention. In a broad sense, glycemic variability refers to a swings of blood glucose levels, including episodes of hyperglycemia and hypoglycemia throughout the day or in different days. And this is what we observe in the so-called unstable diabetic patient. When we look at the glucose variability in an healthy cat, the glucose variability is minimal. When we have a diabetic cat, we have glucose variability. If we repeat, for example, a blood glucose curve for several days, we have totally different blood glucose curves. And this can be a massive difference between blood glucose curves or a modest difference. And we know that when we have a cat with low glucose variability, usually is also the diabetic control is better. And so this terminology that was introduced in human medicine, I think that should be introduced also in veterinary medicine and in feline diabetology. And today, few people are starting to study this concept. So the first thing is how we define the glucose variability, because there are different possibilities to measure this variability, to objectify this variability. The most common method and most simple method is to look the glucose values, the glucose concentration during the day, during, for example, a blood glucose curve. calculate, and we can calculate the mean and the standard deviation. The standard deviation can give us how is the glucose variability. We don't have today big reference ranges about how should be the glucose variability in cats, but soon I'm sure we will have also this parameter. And there are several factors that are influencing the glucose variability. There are some factors related to the owner, for example, the competence of the owner, technical problems, or administration of diabetogenic drugs, or the kind of food that is used, the kind of insulin. And these are all aspects where we can do something. For example, train the owner, explain or improve the compliance. And there are some aspects that are not, where we cannot do too much. For example, severe concurrent disorders, or the insulin that is not working properly in that animal, or the stomach that is the emptying of the stomach that is that has some problems, the absorption. So that we have really many factors, but this and we can really look at this parameter. I think it's a very interesting topic, and if you see in our book, there is a nice description in glucose variability. For example, in chapter 35 at page 333, Claudia Reusch in her chapter did wrote several things about glucose variability, and also the so famous Somogyi effect that we talk for years about this Somogyi effect. There are some people, and I don't have a clear idea if this Somogyi effect exists or does not exist, if there is fully there is the presence of these counter-regulatory hormones, but I'm sure that some of the patient that they were thought as having Somogyi effect probably is just a severe glucose variability in this patient. So we have to discover a lot of things about this, and you know, today more and more we are monitoring our cats and dogs with the devices that are able to monitor the glucose for 24 hours or for several days. And for example, I didn't do in cats, but now I just implanted a few months ago a device that is the Synchronic Eversense, that is a microchip implanted subcutaneously that is reading the glucose concentration in the intestine for 6 months. Now I have a dog. I'm going to try also in a cat, and you can see from your smartphone which is the glucose variability every day, or in the last week, or in the last 3 weeks, or in the last 3 months, and they give you beautiful graphs, and you can adapt the dose. And the technology is incredible, how the technology can help the vet in monitoring the glucose concentration. But the glycemic variability, I think, is a very important concept that should be included in all the next papers looking at the diabetes, the treatment of diabetes.
Thank you, Federico. You know, I'll make a quick comment here, and I think that the concept of glucose variability is so important to present to veterinarians, veterinary students, certainly to owners, so that everyone begins to understand that measuring a blood sugar or doing a glucose curve and using that as the only parameter to determine if a diabetic is receiving too much insulin, too little insulin, too frequently, less frequently than it should be, etc. Using a glucose curve or several blood sugars is really a terrible mistake. I think that we would, again, I'll close the circle back to a previous comment we made a few minutes ago, and that is these blood sugars must be put into the context of what an owner is seeing. Is the owner happy? Is the owner unhappy? And putting that owner opinion with respect to polydipsia, polyuria, polyphagia, and our ability to do a physical examination and weigh this animal. I think those are parameters that have to be included so that we're not just looking at a test result and then telling an owner your cat is underdosed. No, I think we need to talk to the owners as well.
This is extremely important, especially today, that when we are using, for example, these devices that are measuring glucose every second, there are some owners that are really scared about this. They are, because they see the fluctuation, this glucose variability, and I see owners that are terrified by this. And when you ask, but just imagine not to measure anything. How is your cat doing? Oh, the cat is fine. But okay, your cat is fine. So don't worry if you see all this, the fluctuation of all these values. First of all, look at the cat. The cat is fine. Then, okay, we try to improve his glycemic control. Good idea. We avoid hypoglycemia. We want to do the best. But first of all, your cat is fine. This is the most relevant thing. And this is usually when I talk to an owner of a diabetic cat or diabetic dog, I spend at least half an hour telling, don't look at the number, first look at the animal.
It's so important. Any comments, Mark? You okay?
Yeah, I'm okay. You know, Federico, I mean, this is a little off, but I mean, there's a bunch of studies now talking about people, normal people, and glucose variability, even after a high carb meal, the glucose goes up tremendously, you know, for a short time. So, you know, your normal cat owners and so forth. I mean, the same is true even for people, and certainly even for normal dogs and cats and people. There's glucose variability there too. The glucose isn't steady all day, certainly. I mean, it's variable based on what the diet is.
Excellent.
Yeah.
So, Mark, I'm going to go back to you and talk a little bit more about hyperthyroidism. It seems to me that methimazole is super commonly used. And can you give us some opinions on the value of methimazole and why some cats become resistant to methimazole?
Yeah, okay. First of all, methimazole is the most commonly used treatment for hyperthyroidism in cats. And I do not think methimazole is a terrible treatment in general, but it could be the best treatment for one cat and the worst treatment for another. So I mean, I see that saying, well, we treat all our cats with methimazole. That's what we do. That's T4 is high, we treat them with methimazole. You know, and I've talked to people who come to me eventually and they were given no other options or no other choices or no other discussion about other treatment. And I just think that's wrong. So the problem with methimazole is that it's not a cure. Methimazole works by, it's absorbed in the stomach, or transdermally it's absorbed. It circulates around the body and gets taken up by the thyroid gland. And when it's in the thyroid gland, the drug blocks T4 production and secretion. So that's how the T4 lowers. The drug goes into the thyroid and blocks it. It doesn't stop what's going on. Whatever is causing this disease, whatever is causing the thyroid nodules, which become, first is probably a little adenomatous hyperplasia, then adenoma, and it can continue to transform into more of a malignant disease over time. This transformation, this growth of these nodules continues on methimazole. So why do cats become resistant? We see this all the time where a cat's been on methimazole for a year and he was on 2.5 milligrams twice a day, or maybe 1.25 milligrams twice a day, and all of a sudden it's no longer enough and we have to increase the dose. And vets say, I wonder why that is. They increase the dose and it's controlled. And then another year it may go up a little more, another year it may go up a little more. And this is all because this tumor is still growing. As the thyroid grows and the tumor grows, we're going to need more methimazole that goes into that thyroid to block T4 secretion and control the disease. And you will reach a point at some point where you just simply can't give enough, at least in some cats, so their tumor gets big enough. So going back to which is the best treatment? If we just even think about the age of the cat at diagnosis, if you have a cat that's 18 or 19 years of age and he's hyperthyroid, it's very, very, very unlikely that that cat's thyroid condition and tumor will ever grow large enough between the years of 18 and when the cat dies at probably 20 or 21 to be an issue. It doesn't matter. But on contrast, if you have a cat that's 8 or 9 or 10, 11 years old, and they could live a potential of a decade more, it's also very likely in many of those cats that the tumor will grow to the point where the treatments, it's not going to work anymore. It's not going to. So now we have, instead of a 10-year-old cat that's pretty healthy, now we have a 15-year-old cat that's more severely hyperthyroid than he was 5 years ago. He's been on methimazole that people spent all this money all these years, and now it's not working. And now you say, well, we better do surgery. Well, maybe we don't want to do surgery because he only is 15 and he has some kidney disease. Or we say, let's do radioiodine. Well, now it becomes a hard cat to treat, or a much harder cat to treat. So we have to look at all of this. And now quality of life, these poor people have given methimazole for 5 years, and now they have to do another treatment. They spent all the money in methimazole, now they have to do another definitive treatment. So in general, what I like to tell people is we have to look at the owner and the cat, what they like. But in generally, to talk about quality of life for the cat and the owner, younger cats are probably better off definitive treatment. In other words, surgery, radioiodine. You're trying to remove or just irradiate the thyroid tumor that's there. We don't know what the underlying cause of this tumor maybe is. We know that they have this adenoma. Or older cats or cats with chronic disease that probably aren't going to live more than 2 or 3 years, then maybe methimazole or a low iodine diet are the way to go. That's just in general. But there's no single treatment for any cat, and there's certainly, we shouldn't be using methimazole in all cats. We should at least have the discussion with the owners.
And do you want to comment on diet?
Diet plays a role. To me, you know, there's 4 choices. Radioiodine, that some people say, well, that's the treatment of choice. I think it is, but it's many facilities give way too much radioiodine and cause way too much hypothyroidism, which leads to increased azotemia, renal disease, and shortens the cat's lifespan, probably. So if we're going to talk about radioiodine being the best, I think at least we better treat them correctly with radioiodine and not overdose them if we're going to say that's really the best. I don't see any problem with surgery, and people kind of have gone away from surgery, but surgery is still a good treatment for definitive therapy. So we have radioiodine, surgery, both definitive treatments, methimazole, a reversible treatment we talked about, and then diet, a low iodine diet. The low iodine diet is most convenient in some ways because you just feed the food. The problem is many cats don't like it. Many cats won't eat it. They can't eat any other food. They can't go outside and hunt because everything in the world that this cat would eat normally contains iodine. This is not a natural thing. Iodine deficiency, the body does everything possible it can to defend against iodine deficiency. And now we're giving this diet to cause this cat to be iodine deficient, because they have to be iodine deficient, you know, because if there's just a little bit of iodine, that's going to be enough to cause this thyroid tumor to make enough T4 to remain hyperthyroid. So the main problem we have with the diet is about 1/3 to 1/2 don't really, the T4 stays high, never comes down. So let's just say 1/3 it doesn't come down. But even those 1/3, if you look at them, many times they haven't gained weight, their heart rate's still a little fast, and then you put them on methimazole, you do radioiodine or surgery, and now they gain more weight. So it doesn't seem like they're really, really cured as well as the other diets, as the other treatments. Now so you can say, well, are you saying you should never use YD or a low iodine diet? And that's definitely not, because there's some cats that's the only treatment we have. If you have a cat with terrible renal disease or something else, or the people just can't afford definitive therapy and the cat has a problem with methimazole and can't take it, that may be our only option. So that treatment is always better than no treatment in a cat with severe hypothyroidism. So we just have to take each cat individually. And sometimes, let me just say, sometimes what I will do, you don't ever want to give a low iodine diet with methimazole. You don't want to do that as a first line treatment because it's a very potent combination and you can kill a cat doing that. But if I have a very severe cat that's not controllable with methimazole anymore, and I look at the thyroid scan and it's a huge thyroid tumor that looks like it's thyroid carcinoma and the people we can't afford it or something else, sometimes in those cats we combine methimazole with YD, that more potent effect works and we can keep that cat controlled for a little bit longer. So, you know, so again, it's not like we would never use YD. I do use it, but it's not my first. When I talk about a new diagnosis, new cat, what are my treatment options? That would be my fourth choice. I would rather the owners do one of the other three first.